Using a UV lamp to kill the coronavirus. That's just one light bulb moment in a multitude of responses to COVID-19. Cologne was repurposed as hand sanitizer at the beginning of the pandemic. The speed of innovation amid coronavirus could be a game changer, experts say. It could revolutionize global healthcare, allowing us to come up with solutions that could change healthcare delivery. They say necessity is the mother of invention. The coronavirus pandemic has thrown that into stark relief. From innovations enabling us to live with the realities of the virus to devices that make its detection possible. Here's the story of two entrepreneurs who say a diagnosis is just a breath away.
Brothers Jan Christoph and Thomas Wolf have a vision. They want to return some normality to these COVID-19 times. For months, they've been working on a breath test that can identify the novel coronavirus. They are now confident it works.
From a technical point of view, this device can get to areas where normally only a dog can sniff things out.
A device that's almost as sensitive as a dog's nose. The technique is similar to a breath analyzer for alcohol.
What we have here is a sterile mouthpiece. You take off the packaging, and then what happens? You blow into the mouthpiece. You just breathe out.
In their startup, the brothers develop highly sensitive sensor technology for mass spectrometers, for industry and labs for a new type of diagnosis in real time.
We can see all sorts of things using breath analysis, like whether a patient had coffee yesterday afternoon or not. We can identify his nutritional status. We can see different amino acids, different fatty acids, all of this from the breath. Breath is a direct window into the human body.
The brothers believe it could recognize COVID-19. Other researchers also say breath analysis could work in principle to test for the coronavirus.
The challenge is to get the methods that you run on the equipment, the way the equipment is used, the tune and the analytical technique optimized with verified biomarkers that are reliable. Once we've proven that, then you have a COVID-19 breath test ready to go.
Conventional swab tests are reliable, but often only carried out when the infection has been there for a while, and a result usually takes 2 days. The breath test detects metabolic changes in breathing caused by the virus. While it is not yet 100% reliable, it does give an immediate result. The researchers believe that they will be able to deploy the tests as early as next summer in places like football stadiums. Passengers could also be tested at airports before check-in. The accuracy of the test is currently around 80%. However, the researchers are expecting efficiency to increase significantly. In the meantime, a lot of detailed work remains to be done.
People are complicated, and you're looking for a small signal in a snowstorm, a blizzard of information. But we've found the signals we think are helpful.
Jan Christoph and Thomas Wolf originally developed their test for very different types of diagnosis. One problem with the COVID-19 test is that they have not yet been able to carry out studies on patients with the virus. They are hoping for
access to the processes, access to resources to allow us to carry out a validation study on site in a hospital or at an airport test center. And with that, it becomes very easy to determine whether this would be a way to bring back some normality to people.
Breath analyzers could be a way to detect COVID-19 infections much faster than before.
Matthew Harris joins us now. He's a clinical senior lecturer in public health at the Imperial College London. Matthew, so glad you can join us. Now, you've written in the scientific journal Nature about how the response to COVID-19 has been distinguished by so-called frugal innovations. What exactly does that mean?
Well, thank you. Frugal innovation really is the term that we give to the kind of innovation we see under resource constraints or situations of extraordinary time pressure or situations where we don't have the kind of resources that we would normally like to have when we develop healthcare innovations. The word frugal oftentimes is referred to as sort of cheap or good enough innovation, but actually frugal innovation is healthcare innovation that's actually as effective as the kind of innovation we would normally see, but just done in a way that is far more affordable, far more sustainable, maybe with fewer sort of complexity or functionality, but that gets the job done. And under COVID, of course, we've seen around the world some extraordinarily difficult situations at national level in terms of exposing the fragilities in our healthcare systems, but also the real increase in healthcare demand. And it really has necessitated a new type of innovating at pace, rapidly, using resources that we just find around us, so kind of improvising, if you like. And this is the kind of innovation that we call frugal innovation.
So it's about reacting quickly using what you have. But do you have any examples of what a frugal innovation could be?
Well, absolutely. In the early days of the COVID response, we saw in several developing countries some really interesting examples of frugal innovation. So, for example, where there was a lack of personal protective equipment, we saw clinicians improvise the use of simple acetate sheets, the kind of acetate sheets that you'd use for overhead projectors in the old days. And by simply putting some holes in either side of the acetate sheet and threading some ribbon on either side, those became very effective face visors to protect not only the clinician but also the patient in front of them when they were intubating. And this was, of course, extremely cheap and actually very, very effective. Since then, face visors have evolved and become more sophisticated, but it was a very good example of a frugal innovation at the time. Another good example of innovating at pace was the construction of hospitals in under 10 days in China. And actually, eventually, also in the UK, where I'm from, we saw the construction of, or repurposing at least, of conference centres into intensive care units and hospitals, also in very, very short amount of time. So this sort of idea of repurposing the resources you have, but also very, very quickly, is characteristic of frugal innovation.
Now that the crisis has focused minds and mobilized so much in terms of responses, as you've told us there, is there also kind of downside to this kind of concentration of response to the crisis?
Well, I think the COVID obviously has required a deviation of resources from other areas of healthcare to focus our attention on the COVID response. And as a result, some other areas have, if you like, suffered in terms of research going into them and also healthcare delivery for different clinical conditions. I don't think there's a downside to frugal innovation. I think it's been really revealing how we've been able to develop such effective healthcare responses in a short period of time. And without scrimping on safety checks or effectiveness or clinical effectiveness for the patients that we serve. So I don't see a downside to frugal innovation, which tends to be far more affordable for healthcare systems, as long as the necessary checks and balances are in place to ensure safety of those devices or technologies.
You've written that this kind of innovation could lead to a leveling in global healthcare equality. What does that look like?
Well, it's a leveler in the sense that COVID has made us really reflect on the fragilities in the health systems, even in high-income country settings. And it's made us pay much more attention to the kind of innovations that arise from low-income countries. It's something we've been advocating for many years. And what COVID is doing is making us pay, therefore, more attention to settings that traditionally we haven't really noticed in terms of healthcare innovation.
Thank you. Matthew Harris there talking about putting human resourcefulness at the center of our COVID-19 response. He's a clinical senior lecturer in public health at the Imperial College London. Thank you for your insights. And now it's time for one of your sent-in questions about the coronavirus. Our science correspondent, Derek Williams, is ready with an answer.
Taking into account a patient's sex and age, what do the statistics say about complications?
One of the clearest pieces of information that's come out of the statistics is that from the age of about 40 on, women in general are a lot less likely than men to have severe outcomes. Data from both the CDC and the European Center for Disease Prevention and Control reveal how stark the difference is. This graphic, for example, emphasizes how much more likely men of a certain age are to end up in the hospital or the ICU. Numbers of men are represented by the blue bar and numbers of women by the red one. In Europe, men between 40 and 80 make up around 3/4 of all intensive care cases and recorded deaths. After 80, the split is more even, but that's almost certainly due to the simple fact that a lot fewer men live to that age. So statistically, the chances are a lot higher that in the over 80s, a woman is going to get COVID-19 than a man is going to get it. There's a lot of speculation about why, and there doesn't seem to be a single reason that accounts for all of the discrepancy. Several factors are likely playing roles. We know, though, that people who have diabetes or high blood pressure or heart disease are at greater risk of severe outcomes if they contract COVID-19. And aging men are more likely to have those comorbidities than aging women are. But another possible contributing factor involves immune response. The male and female immune systems are different, experts say, because on their second X chromosome, women have another copy of many of the genes that are involved in fighting off disease. It's been theorized that's also why women are more likely to develop certain autoimmune diseases than men. But in this case, it could be helping them keep COVID-19 or its medical ramifications more effectively at bay. That's hard to prove, though.